So, are you able to see our screen, sir?
Just give me a minute. I'm just setting up the live stream.
Okay, sir.
Who will start the presentation?
Sir, so Shejin will start with the history.
Okay. And this is a different case from last week, isn't it? That was operable, locally
Yes.
advanced operable oral cancer, tongue cancer, and today is
It's a
inoperable.
yes, sir.
Yeah, it's an inoperable. Just give me a minute. It's just setting up the live streaming. Unable to live stream. Configuration. Oh dear. Just give me a minute. That live stream is.
Yes, sir. Yes, sir.
Yeah, it's happening. Okay. So good morning, everyone. I think this is. So today is the last presentation and discussion on oral cavity. So we had early stage oral cavity. It was buccal mucosa. That patient had trismus also with submucous fibrosis. Then we discussed locally advanced but operable oral cancer, which was a case of CA tongue. And today is an inoperable locally advanced oral cancer. And we will have the discussion today. And then we will move on from next week to the other head and neck sites. So Anuj, do you have any comments on the case selection? And they have shown you this case. You want to say anything?
Yes, sir. So I have gone through this case, and this is a
Hmm.
treated case of oral cancer to begin with, and
Yeah.
I think this is a good case for discussion. We can have many points for discussion
Okay.
here, so they can start.
Okay. Please start.
Okay. Good morning, everyone. We have a case of unresectable carcinoma oral cavity, buccal
Can
mucosa.
you make it full
Yes,
screen,
sir.
please? Full
Sir,
full
this is
screen, please.
full screen from my side, sir. Are you able to see?
In the
So we are
present.
not.
No, it is in the present, not in the presentation mode.
Just 1 second, sir. I'll
You
just.
go to the presentation mode. This, yes.
Share screen.
Like,
No. It's not presented.
can't say anything.
Sir. Sir, what about now, sir? Are you
What
able
was
to
on
see?
in full mode?
It's
Now,
not in
don't
full
see
screen mode
anything.
even now.
Okay.
Yes. Yeah, we can see now the slide, but it is just put. Yeah, able to see, but not it is full. It's not in the presentation mode.
Um,
Yeah, move your cursor down on the bottom where it is.
yes, sir. But okay, yes, now it is. Sorry for the delay, sir. So we'll start with the case presentation. Uh, Patient is a
Sorry,
45 year
now
old.
that it has, it's not seeing. Hello, hello, hello,
Sir,
hello. Now it has become blank, black screen. We are seeing. We are seeing a black screen. Yeah,
Sir,
now we are seeing. Yes.
yeah.
sir, now.
Okay.
So he's a
Finally, you got
45.
it.
Yes, sir.
Start.
He's a
Carry on.
45 years old gentleman who's a
Forward.
resident of UP, electrician by profession with no comorbidities. He presented to us with complaints of progressively increasing right inner cheek growth for the past 6 months and progressively increasing right lateral neck swelling for the past 6 months. Coming to the history of the presenting illness, patient was apparently asymptomatic 6 months back when he noticed a known healing ulcer at the right inner cheek following a tooth extraction, which gradually increased in size over the 6 months, and it was associated with pain and restriction of mouth opening. He also noticed a swelling in the right side of the neck over the last 6 months. Initially, when he noticed it was 1 centimeter in size, which increased to the current size of 5 centimeter. He does not give any history of pain radiating to ear, no bleeding discharge from lesion, no symptoms suggestive of metastasis like cough, hemoptysis, dyspnea, no history of pain, abdomen, yellowish discoloration of eyes, no history of bone pain, no history of loss of appetite or significant weight loss. He does not have any comorbidities. He does not have any history of TB or any other chronic illness. He is a cigarette smoker for the past 20 years, 5 pack years, and he has reformed since 2 years. He also gives history of gutka chewing 5 times a day for the past 10 years, and he has reformed since 2 years. He has a family history of cancer. Coming to the summary of the history, he's a 45 years old gentleman with history of gutka chewing and cigarette smoking of 5 pack years, presented with progressively increasing right inner cheek growth and right lateral
Your
neck swelling for the
sound
past
sort
six
of in
months.
between just sort of fades away. I don't know whether you're in the poor signal area or you're speaking.
Sir, is it audible now?
Yeah, now it is better. I think in between you move away from the mic, so yeah, it is
Okay, sir.
audible now.
So
Clear.
should I repeat the history, sir?
No, no, that's all right.
Okay. So coming to the summary, he is a 45 years old gentleman with history of gutka chewing and cigarette smoking of 5 pack years, with progressively increasing right inner cheek growth and right lateral neck swelling for the past 6 months, and likely to be neoplastic growth of oral cavity. Coming to the general examination, patient was explained about the
Sajal,
examination. Yes, sir.
can I stop you here for a moment?
Yes, sir. Yes, sir.
Yeah, so you told cigarette smoking since 20 years. So
Yes,
you
sir.
made it as 5 pack years. So can you tell what is pack years and how did you derive at this 5 pack years and how will you account for the gutka chewing? Because if you tell the pack years is 5, then it may mislead the listeners thinking that the patient has a history of 5 pack years only. So how do you quantify this gutka chewing also into account? Do you know how you can do that?
Sir, for the pack years, cigarette smoking, one packet has 20. So you have to ask the patient how many number of cigarettes he smokes every day. The number of cigarettes he smokes every day divided by the number of cigarettes in one pack into the number of years he has smoked becomes the pack years. Sir, but I'm not aware how you incorporate gutka chewing into the pack years, sir.
So
See,
for
in the last meeting, I had said that it's easy to calculate pack years, but for the smokeless tobacco, how to quantify? Okay, so that was something for you all to read. I think today, if you all don't know, but please read all of you And in the comments of the YouTube link, please, one of you add all whatever you have understood or what you could read about quantifying smokeless tobacco.
Okay, sir.
Yeah, so normally if you tell Gudka chewing, if he take one pack, like for example, you have told here 5 packs per day, right? So
Yes,
that's
sir.
why 5 packs you can like approximately tell one Gudka is equivalent to 1 to 2 cigarettes. So like
Okay.
that, when you calculate the pack years, you can actually give a combined pack years in total, rather than
Okay.
just telling only about cigarette smoking and leaving the Gudka pack. Okay, go ahead.
Okay, sir.
Yeah.
Okay, sir. Thank you, sir. Coming to the general examination, patient was explained about the examination procedure, examined in sitting position in a well-lit room after taking verbal
Okay.
consent.
Okay. So accordingly.
He is a moderately built and nourished man with a weight of 62 kilogram. He is conscious, oriented, and alert. General condition is good, and Karnofsky performance score is 80. There was no pallor, clubbing, icterus, or edema. Systemic examination was within the normal limits. Coming to the local examination, on inspection, mouth opening, the interincisor distance was 3 centimeter. Poor oral hygiene was noted. Tobacco stained teeth and dental caries. Oral submucosal fibrosis was noted. Tongue movement was not restricted. The lesion is an ulceroproliferative growth of 4 centimeter in greatest dimension, with in right involving right buccal mucosa and right upper alveolus. Anteriorly, it is reaching up to the right upper first premolar, posteriorly reaching till the RMT. Superiorly, it is involving the upper right GBS, and upper alveoli is eroded. Inferiorly, the lower GBS and retromolar trigon is free. Medially, it is extending till 1 cm in the hard palate, 1 centimeter from the midline. Laterally, the skin appears free. No active bleeding or discharge. No orocutaneous fistula noted. The pictorial representation of the same is given in the slide. Um, you can see the lesion colored in the red. So this is the lesion. Anteriorly, it is reaching till the right first premolar. Posteriorly, it is reaching till the RMT. Medially, just 1 centimeter short of from midline in hard palate, and upper GBS is included. This is the buccal mucosa extent of the lesion described, and lower GBS is free. On palpation, the inspectory findings were confirmed. It's an ulceroproliferative growth of 5 centimeter in greatest dimension with a thickness of 1 centimeter. Firm in consistency and tenderness was present. The lesion is fixed to the underlying structure. It was not bleeding on touch, and there was no altered sensation over face. Examination of neck. Right neck showed have conglomerated level 2 3 lymph node of 4 centimeter in greatest dimension, which was hard in consistency. It was non tender. It was fixed to the underlying structures. It was not involving the skin. There was no active bleeding or discharge. According to the history and examination, we come to a provisional diagnosis of 45 years old gentleman with progressively increasing right buccal mucosa growth and right lateral neck swelling since 6 months, likely to be carcinoma oral cavity, likely to be originating from the right buccal mucosa. Clinical staging of T4B and N3B, MX as per AJCC 8 staging.
Shajin, can I
Yes,
stop you
sir.
here?
Yes, sir.
So the thing is, you told the stage is a query CT4B. That's what is
Yes.
mentioned here.
Yes,
So,
sir.
when you clinically examine the patient, you should reach at a clinical T staging. So here, even if you don't know what is the superior invasion of the disease, clinically you
Okay.
should be able to tell. So
Hmm.
clinically, what is your stage? So there, it can't be a query.
Query.
You can tell it query for now because you haven't got the radiological imaging done. But
Yes,
still,
sir.
at this point of time, you should be able to tell what is the clinical T stage. So in this patient, with the available findings that you have done
Yes,
or
sir.
you have taken, so
Yes,
how
sir.
will you stage this? Like, is it like, can you stage it like in any other way? what is T4A of the oral cavity?
So, T4A of oral cavity is the tumor dimension of more than 4 centimeter and DOI depth of invasion of more than 1 centimeter, or any size which is involving the skin, mandible, maxilla, or maxillary sinus. So, this is definitely at least a T4A. But since the patient has restricted mouth opening, I was suspecting masticator space is involved, so it
Yeah.
is likely to be a T4B.
Yeah, so because you haven't done the imaging, now we don't know exactly whether it is T4B or not. But as per your clinical staging, it is at least a T4A. So when you
Yes.
stage clinically, you can stage it as a clinically, it is a T4A disease now with the
Okay.
available findings you have. And when you go to the radiology, then you can confirm whether it is a T4A
Okay.
or whether it is a T4B.
Okay.
And what is N3B that you have mentioned here?
N3B is so the node is a 4 into 3 centimeter with fixed to the underlying structure. So we are suspecting there is extranodal extension. Thus, we have staged it as N3B.
Okay, fine.
Yes.
Sir,
So
you
can
want
I?
to add any
Shajin,
thing here, sir?
Yes, yes, ma'am.
I want to ask you,
Yes.
is there any such terminology as MX now in the current edition of AGCC? MX?
Uh, no, ma'am. It's either M0 or M1.
So yeah, so MX actually has been eliminated from the staging system.
Okay, okay, ma'am.
Yeah.
So better to write as M0.
Okay, so as per clinically, we will write as M0.
Yes,
Okay.
yes, as per the
And
history and examination. Yeah,
okay, okay. Thank you, ma'am. Can I proceed?
yeah, please.
Okay. Now, we would like to go ahead with the investigations. We'll do the routine investigations, which include complete blood count, the biochem, the serum electrolytes, and viral markers, most importantly, before we proceed with imaging and biopsy. Then we would like to do a CECT head and neck thorax with puffed cheek for the staging of the disease. So this patient, he got a CECT head and neck done outside, which showed a 3.9 centimeter lesion, a right buccal mucosa lesion in greatest dimension with DOI of 15 millimeter, which was involving the retromolar trigon, gingivolingual sulcus, masseter muscle, masticator space, IT infratemporal fossa, high ITF, retroandral space, the pterygoid muscles, pterygopalatine fossa, pterygomaxillary fissure, maxillary sinus, maxilla upper and upper alveolus. The scan also showed a metastatic right level 1B and 2 node with at right level 2 it's 4.2 centimeter in dimension with perinodal extension. There was prominent retrocrural and retroperitoneal lymph node which was indeterminate. So we reviewed the scan and then we went ahead with the biopsy from the lesion, which showed moderately differentiated squamous cell carcinoma. Now, since there was a prominent retrocrural and retroperitoneal lymph node which was of indeterminate origin, we decided to go ahead with PET-CT for staging. The PET-CT showed a 4 centimeter avid right buccal mucosa lesion, which is with the extent as described previously, that is extending into gingivobuccal sulcus, retromolar trigon, involving the alveolus, extending superiorly into right maxillary sinus with erosion of the walls and eroding pterygoid plates, right alveolus. Now, there was avid right cervical level 1B to 3 lymph nodes and metastatic level 2 lymph node with intact fatty hilum. This left level 2 was considered to be reactive, and few enlarged low avid retrocrural and retroperitoneal, which was 3.6 centimeter with low uptake. There was no lung nodules. So we decided to confirm the we decided to go ahead with biopsy from the retroperitoneal lymph node, which was of 3.5, 3.6 centimeter. Before that, I'll show you the CT slices. So we've taken the slices from the PET CT. So this slices goes from inferior to superior. Now you can see the lesion here. Now this is the right buccal mucosa lesion. This is involving the right buccal mucosa. Now this is the lesion here, which is involving the maxillary sinus. You can see some maxillary secretions along with the mass. These is the going superiorly to involve the masticator space and the pterygomaxillary fissure.
Can you, Shajan, can you go to the imaging once more?
Yes,
And
sir.
can you tell about the nodal status also? Because you have also displayed some images where you can see the nodes to some extent. So you see, the thing is, you describe your lesion as something which is in the right buccal mucosa upper alveolus region, right? But
Yes,
then
sir.
when you told this is the lesion and you had shown below the mandible. So do you think that is the origin
Uh,
of the primary, or is it something
no,
else?
that could be node, sir.
Yeah, that is the submandibular node that should be enlarged, no? So
Yes,
that is not the primary tumor like you have described. And
yes,
yeah, so can you go to the next image there?
yes,
So here, can you see anything else in the node? Like that's okay. That is where your
this one.
like upper alveolus is, and you can see the buccal mucosa lesion there. But can you see something? Yeah, the node also. Yeah. So when you are describing the image, describe your primary as well as your node when you are
Oh,
reading your CT scan. Okay.
oh, okay, sir.
So yeah. So this is the node. So which level does it correspond to?
Level 2 lymph nodes, sir.
Okay. So when you go to the next image. So here you can see the maxilla getting eroded very well, and you can also see at the pterygoid plates, at the origin of the pterygoid plate, still there the disease is extending. And can you go to the next slice?
Yes, sir.
I think at this level we can see the retroantral, the area that is behind the posterior wall of the maxilla. That is also like kind of the space is effaced as compared to the contralateral side, as
Okay.
compared to the left side. Okay, so there you can again see the disease going. And next, yeah, so here at the level of your pterygomaxillary fissure and fossa, there is some what do you tell? There is a little bit of uh, intensity density change at that area. So that is very what they have mentioned as pterygo maxillary fissure involvement. Okay. Yeah.
Okay. Then, so the retroperitoneal lymph node biopsy done was reactive. So this becomes clinically M0. Now, we decided to do MRI for the local staging to see the intracranial extension as well as the perineural involvement. So it showed a right maxillary alveolar growth extending into the buccal mucosa with involvement of the ITF, retroantral fat space, upper GBS, GLS, masticator space, infratemporal fossa, the pterygoid muscles, pterygopalatine fossa, pterygomaxillary fissure, and maxillary sinus. The masseter muscle, skull base, mandible, prevertebral fascia was uninvolved. The vessels were abutted with less than 180-degree. Right IJV was focally compressed, and there were metastatic right level 1B to 3 nodes of 4.2 centimeter dimension with PNE. Indeterminate left level 2 node. Now showing the lesion in the MRI. So the lesion is contoured. You can see the lesion which is extending superiorly into the to reaching the RMT. Okay. Now, coming to the final diagnosis, this is a case of oral cavity, moderately differentiated squamous cell carcinoma, right buccal mucosa, clinically T4B, N3B, and M0. And in view of in view of the pterygopalatine fossa and pterygomaxillary fissure involvement,
So,
this
Shajan, last
yes,
time we had
Yeah.
discussed that how MRI is useful to
Yeah.
detect
Yeah. Yes, sir.
ozone
Yes.
spread. In addition, what else in one of those pictures, MRI is good in distinguishing between disease and something else? In the maxillary cavity, if you go to that,
The secretion, sir, the maxillary
so
sinusitis
otherwise in
versus.
CT, I mean, you can suspect, part of it is secretion, but here because of the different, signal intensity of fluid,
Intensity.
you are able to see it well. Okay, normally
Yes.
this we don't discuss when we, discuss. So in your slides, it is seen quite well. Carry on.
Yes. Okay. Thank you, sir. So, the now the further plan for the patient, the case, he was deemed unresectable in view of pterygopalatine fossa and pterygomaxillary fissure involvement.
Not
So,
he was deemed unresectable. The cancer was deemed unresectable.
okay,
Okay.
sorry, sir. Cancer was deemed unresectable. Then we
Shajan,
planned.
can I stop you here 1 second?
Yes, sir. Yes, sir.
This is Shweta. Why was the MRI done to the pterygomaxillary fissure fossa involvement was seen on the CT itself, right? There was some
Yes.
doubt, so MRI was done. And
Yes.
then, so we did 3 imaging for this patient, a PET CT and an MRI and a CECT, and
Yes.
then to call this patient unresectable.
Mm.
And
Yes, sir. Baseline CT was done outside, and we had a few films of the thing which was reviewed here. PET CT we done for the systemic staging. Then there was the CT done outside was query. It was suspicious, also we did repeat MRI for local staging to see the intracranial extension and to ascertain the extension of pterygopalatine fossa and pterygomaxillary fissure.
okay.
Then we planned for neoadjuvant chemotherapy followed by assessment. Um, Patient
So
received.
what are the so when you say, I think the discussion question answer, when do we consider it unresectable? So you have mentioned these two factors. What are the other
So
what are the
Prati
other?
here. Hello.
Yes, yes,
So
yes,
can you hear me? So,
yes.
surgically unresectable disease we can classify as absolutely unresectable disease and technically unresectable. That is potentially resectable. So, sir,
Okay.
in absolutely unresectable, the R0 margins is cannot achieve. So the it can be extension of the tumor to the base of the skull when there is prevertebral muscle involvement and there is encasement of invasion of carotid arteries. And so in technically unresectable depending on the site of primary, when if it is buccal mucosa and if there is peritumoral edema or it is going up to or above the level of zygomatic arch, then it is technically unresectable. In case of sir tongue primary, when the tumor is extending to the vallicula or up to or below the level of the hyoid bone, then it becomes technically unresectable. And when there is extensive skin infiltration and it is impacting the achievement of negative margin, it also can be so technically unresectable.
Okay, got it. So, but what's the problem? Even if you can get a R plus margin, resect it like in ovarian cancer, we do it. So in head and neck cancer, when the surgeon, based on clinical or radiological evaluation, is almost certain that he or she will not be able to get R0 resection, or it will be like a grossly positive margin. So why is surgery not considered in head and neck, whereas it is done in ovarian cancer and some other cancers, brain tumors, ovarian cancer.
So when there is yes. So when there is R plus resection in head neck cancer, the outcomes are not favorable. Sir, the locoregional control will be compromised, and also the sir, functional outcomes won't be favorable in head neck cancers.
I think that's important. So even after doing such a morbid surgery, giving functional deficit, cosmetic, and then also you do not improve the cure rates by doing a grossly positive margin, and then if you add radiotherapy to that, will not change the outcome. Okay, so that is the important thing that you do not. Whereas for other cancers, we know that for ovarian cancers, we know that debulking helps. So the name of the surgery itself is like that. So carry
Yes.
on.
So then the plan was neoadjuvant chemotherapy followed by assessment for surgery, and patient went to on to receive 3 cycles of neoadjuvant chemotherapy which included paclitaxel at 175 milligram per meter square and carboplatin, triple OMCT, and nivolumab. Post NACT, he had good clinical benefit. His mouth opening increased, and the size of the lesion decreased to 3.3 by 3 centimeter. And yes, but
So, sorry, just go
One
back.
second. Yeah.
Is this a standard dose of nivolumab? I mean, you can't just write nivolumab 40 mg. What? Is it oral or it is how it is given, everything
it's
else?
IV, sir. It's IV.
IV. So it is a standard dose nivolumab or low. See, you may not know everything about, all the medicines, but the drug treatment which your patient has received, you have to know that. No? Any one of you who's presenting, would you like to comment? And from where does this dose comes? So paclitaxel and cisplatin and carboplatin are, well established, this thing. So what is the basis? We will have discussion later on the systemic therapy. Do you have any slides on systemic therapy or not?
I don't think so. They have a slide later on.
So Anuj, then just ask them about this only. So from
Okay. So, Shajin, so what is the nivolumab? What class of drugs does it come under? And
It's
yeah,
it's a monoclonal antibody inhibitor.
so do you know something called PD-1, PD-L1? What is an immune checkpoint inhibitor?
Yes, a PD-1 inhibitor.
So nivolumab is a, yeah, you can tell.
PD-1 inhibitor, sir.
So other than that, you have also mentioned, so you have told the patient has received Pacli and Carbo. What is AUC? What is AUC 5 that is mentioned here? And is it a weekly regimen or a 3-weekly regimen that you didn't mention when you tell the NACT or any
you
form of
can never
chemotherapy?
you cannot write a chemotherapy water just like that. Paclitaxel plus, you have to write, see, I have written cycle 1, cycle 2, cycle 3. Okay, you have written the cycles.
Three
So,
weekly cycles given, sir.
okay, 3-weekly cycle was given. Okay, and what is
But
what is AUC?
you don't have to leave us for us to figure out it is weekly or 3 weekly. You have to write properly. Okay.
Sorry, sir.
So, like when you write a radiotherapy prescription, there's a way to write. Similarly, when you write what patient has received chemotherapy, there's a way to write what chemotherapy was given and how it was given. Okay.
Yes, sir.
Yeah. So, what is AUC, Shajin, and what is AUC 5 that is mentioned here? Do you know?
So AUC is the area under the curve. So for carboplatin, we do not calculate the required dose based on the body weight. We calculate it based on the GFR. So
Body weight or surface area. Okay. Not
body weight or surface
hardly
area.
any drug we calculate on body weight.
So, how do you calculate the dose? You will have to know how you calculate the dose of carboplatin with this area under curve. So, you have to also know what is the GFR of the patient and calculate the full dose of carboplatin that is required. And you also mentioned about OMCT. What is OMCT? And
OMCT is oral metronomic chemotherapy. These are chemotherapeutic drugs which are given in small doses frequently for a long period, sir.
no, so here you told there are 3 drugs mentioned here, right?
Yes, sir.
Celecoxib, erlotinib, and methotrexate. Do you know how much, is the dose that has been given? Because this is on a protocol also. So you have to know if you are telling a drug, what was the dose of celecoxib? Do you know what is the dosage of these 3 drugs?
For this patient, celecoxib was given 200 milligram BD, 2 times a day. Erlotinib was given 150 milligram OD, and methotrexate, I'm not aware about the dose.
So it is
It is
I think in
9.
mg per
future,
meter
please,
square.
just
Yeah.
one second. In future, please write the full prescription. Can't just write the names. This was given as part of NACT. This is not just some homeopathy treatment which patient took. You can't just write one line like this. Okay, it should be, you have ample space in the slide. You could have written properly.
Yes, sir.
Carry on.
Okay.
Response PET-CT done showed significant decrease in the size and metabolism of the primary disease as well as the nodes. Previous with SUV uptake was 21, now it is 3.79 in PET-CT in primary, and there were no new lesions. And this was rediscussed for the feasibility of the surgery, but in view of the persistent pterygomaxillary fissure and fossa involvement, the cancer was deemed unresectable, so we decided to go ahead with chemoradiotherapy. The post NACT staging is carcinoma oral cavity, buccal mucosa, moderately differentiated squamous cell carcinoma, YCT4B and YCN3B, YCM0. These are the response PET-CT images. Now,
Could you
Dr.
go
Prach.
for the plan, Shajin?
Yes,
So,
sir.
in a patient who presents to you with a large unresectable disease, so for this patient, they gave a neoadjuvant chemotherapy. They treated aggressively because he was a relatively young patient who was 40-year-old, and they thought in case NACT can be given and downstage, they may consider for surgery. But here, to begin with, there was query involvement of the pterygomaxillary fissure, so it was difficult that the patient gets resectable also later on. So that is something we need to know here. And in a situation when you think upfront the patient is unresectable, like now there is gross dissection, there is involvement of the maxillary sinus. Like I'm telling a scenario where there is more extensive disease than this, then do you think will you follow the same protocol, and what will be your intent of treatment here, and how will you counsel the patient?
So when the patient is borderline resectable patient, first we will evaluate for NICT, and if the patient is fit for NICT, we'll go
Who's
ahead
this
with.
Prachi? Is that Prachi?
Yes,
Who's
sir.
yeah, okay.
Yeah. Sir, we first will evaluate for NACT. If the patient is fit for NACT, after NACT, we'll re-evaluate for surgery. If it becomes operable, then we'll go ahead with surgery followed by post-op RT with chemotherapy, depending on the histopath report. Sir, if there is a response, but still the patient is inoperable, then we'll go ahead with chemoradiotherapy. If the patient doesn't respond or if it progresses, then we'll go ahead with RT, sir. If the patient is not suitable for NACT and a younger patient, if the performance status is good, then we'll go upfront CT. If we'll do sir upfront CT-RT. If the patient is older or the performance score is not that good, then sir we'll give we can plan for hypofractionated RT. If the patient is obviously palliative or the performance score is not good, then sir our intent of treatment will be palliative, sir.
So, what I wanted to ask here was that this is a borderline resectable cancer, and you have
Yes.
given NACT. What is
Yes,
the
sir.
response rate of NACT in this group of patients? Like you give NACT to 100 patients who have got borderline or technically unresectable. So how many number of patients respond to NACT, and do you have any data to suggest that? Anyone, not Prachi, anyone of you who is a part of this can answer. So, what is the response rate of NACT in borderline unresectable oral cancers? That is my question.
So, so the response rate is around 30 to 40%, sir, in borderline resectable cancer.
Okay, yeah. So, we have a study from our institute only that
Yes, sir.
shows
Yes,
about around 35% response to NACT.
yes, sir.
Okay, yeah.
Sir, so for this patient, as the uh, uh, primary tumor was going into the ITF, we decided to go ahead with IMRT plan, sir. So for this patient, the target volume was for GTV primary, the gross tumor volume was which was visible, and pre-chemo extent of the disease was also taken into consideration. For GTV and gross node visible on planning scan, the high-risk CTV primary was including GTV primary plus 5 mm margin. High-risk CTV for for nodal was bilateral level 2 node, right level 1B node, and low risk CTV bilateral level 3 nodes, bilateral 1B node, right level 9 node, and right 5A node, sir.
So,
Sir,
Prachi, can I ask you what is right 5A? What group of lymph nodes are that? 5A, and why have we included 5A group here? So, you told you have included your high risk bilateral level 2 and right level 1B. So, why did you include 5A here, and why not on the contralateral side then? And what is right level 9 node? Can you name what is the
Bucco fish.
like
Yes.
Bucco facial? Okay, so what is 5A, and why did you include it here?
So according to Julian Bow paper, sir, as it was N3 disease, so sir, in low risk volume, it consists of level 1, 2, 3, and 5A, B, sir. So because according to that paper, I have mentioned 5A.
So yeah, so we don't follow everything based on that single paper of Julian Bow. That is a good guideline that has been given, but sorry, I got it. So that is a good guideline to refer to. But for this patient, when you tell there is right 1B, 2, and 3, maybe it is because when you have nodes that are reaching at the edge of the sternocleidomastoid, where there is a junction between the 5A, between the posterior triangle and the anterior triangle, that may be the reason why the 5A node would have been included. Okay, so don't it will be a patient specific nodal contouring, and you have to tell based on your patient why did you include this volume. Okay.
Yes, sir. So sir, 5A is upper posterior triangle node uh, that you had asked.
Okay.
So for this patient, this in this slide you can see the GTV primary contoured. So this is the GTV end contoured. So sir, this is the GTV primary. The 5 mm margin is given to GTV primary. This is CTV primary, and 5 mm margin to the, and CTV is 5 mm margin to the CTV is PTV, sir. So this is low risk volume. This is the 95% coverage on IMRT plan. So this is the slide showing the low risk
What
volume
kind of
of.
IMRT is this?
So VMAT, sir.
Okay,
What
carry
is
on.
VMAT, Prachi? Expand VMAT.
Volumetric arc therapy, sir.
Volumetric, or is there something? What is M then?
Yes, sir.
Modulated. Yeah. Okay.
Yeah.
So, Prachi, do you think?
So for
Yeah. So, why was IMRT planned for this patient? What if you plan with conventional portals? So, you can show the portals that you roughly made for the conventional
So,
treatment.
yeah, show the conventional portal and we can discuss between the two.
so sir, this is the conventional portal. So this is bilateral portal as the disease was crossing midline on the MRI, sir. So we use the bilateral portals. So the superior border in
Disease
this
was
case
not
is the
crossing the
zygoma, sir.
midline.
Posteriorly,
You mentioned the disease was 1
sorry,
centimeter
sir.
away
No,
from
no,
the
no. So,
midline, right? It is
so
because of
in this,
bilateral neck
I
nodes,
mean,
right?
yeah, bilateral lymph node, sir. Left level 2 node was involved. That's right.
Okay, so what do you think would have been the benefit with addition of IMRT for this patient? So you do the conventional portal. Can you show the like slice where the target volume has been drawn with the conventional? I think next, can you go next and next? Next slide. Okay, so yeah, you can see that what portals you have drawn is not ideally covering the high risk CTV that has been drawn here. So this is a routine portal that has been put. So with this, you can tell if you like place a conventional portal for this patient, what will be the uh, like issues that we will face here. And
what will
what
be
is
the
the benefit that you
anatomical
get?
or radiological landmarks? You want to cover the entire buccal mucosa, gingival buccal mucosa, superiorly, where it should be. You can feel something, you can see something on X-ray.
Yes, sir. So, sir, superiorly we can see, sir, the zygoma. This is the surface land radiological landmark. So, these are the spinous processes, and so inferiorly the clavicle.
Okay.
Okay, so for this patient, Prachi, based on the superior extent of the disease, the actual portals would have been quite high, right?
Yes, sir.
Yeah, so what will that cause? What toxicities do you anticipate if you treat this patient? Because when a patient comes, especially in an unresectable setting, extensive disease, you need to know why you are giving a particular technique of treatment and why not another one. And what are the toxicities you anticipate between the various techniques that you finally decide for the patient. Okay, so that is important to know why you use a particular technique. Okay,
Sir, so
and
if in this,
yeah,
sir,
you can tell. Yeah.
in this patient we had, if we had decided to go ahead with conventional plan, the primary disease was going higher up, sir. So if we increase the portal to include that disease, so the eye doses will be high. So ocular toxicities and yeah,
Okay,
so doses to
okay, so yeah, so your eye toxicity will be significantly higher when you treat with the conventional portals for this
yes,
patient.
sir.
That's what you mean to tell, right? Okay.
Yes, sir.
But other than this, for example, uh, we talked about this patient who was treated aggressively with a neoadjuvant chemotherapy approach and then chemoradiation, that too with a intensity modulated radiation therapy. So for another case, if the patient had inoperable disease and you know that the patient is not going to benefit with NACT, so it is extensive disease, and the intent of treatment becomes palliative. Then how do you want to treat this patient if this is a palliative treatment? And do you know of any fractionation regimens also in unresectable cancers in head and neck, which have been practiced world over and in
So,
our institute also?
there is one
Any
paper
more
from
slides
our
you have
institute
on
only
the
for
presentation
dose
technique?
fractionation.
Because we have 15
No,
minutes
sir.
left. Just Anuj, can they just quickly show what the technique? Then we will discuss. Have a question answer session.
Yes, sir. So I think, do you have any theory part also,
Any
Srijan?
additional slides on this conventional portal? Anything else you have?
No,
No,
sir.
sir.
Okay. Your phase one, phase two. Just sorry, go back. So, okay. So this was. So why you have drawn this portal and then showed again? So this would have been your conventional
So
portal.
if we had to plan with conventional too, and here we wanted to convey that conventional portals are not adequately covering the disease. That, and thus
Superior
we went
extent
ahead
of
with
the disease.
IMR.
Superior extent of the
Yes,
disease.
sir.
Okay? So don't just say high,
Yes,
low,
yes.
front, back. You always use anatomical terms in radiation oncology. Superior, inferior, anterior, posterior. Okay? So that was inadequate.
Okay, sir.
So, so total
Sir, so
dose
this
46
and
and 23.
20, yes, sir. So
Parallel
this dose,
approach. Yeah.
so this in phase one we restrict the dose till 46 day in 23 fraction to limit the dose to the spinal cord, sir. In phase two, we will use shrinking portals where we can avoid the dose to spinal cord, sir. So
Basically,
that's
you
what
have
we.
come off chord. Okay?
Yes, sir. Of course, yes, sir.
Off chord. So in this case, it was not possible. Now tell me, where do you prescribe the dose?
At the in bilateral techniques, sir, at ISO center, sir.
At ISO center. ISO
Yes.
center. So, okay. At ISO center, mid plane. Okay.
Yes,
So
sir. Yes.
this has to be SSD or could be SAD, SSD. What kind of parallel oppose could be either way.
Sir, uh, sir, parallel oppose SAD technique, sir.
SAD technique. If
Yes, sir.
suppose there was no superior extent of the disease and you have to give full dose, radical dose. Suppose you were treating a patient where you don't have feasibility of giving IMRT, or even though you may have a machine, every patient cannot be accommodated on a machine on which IMRT can be given,
Hmm.
and you had to give radical dose. Then
Hmm.
anything else you could have done during your conventional radiotherapy?
So if in this patient we have to go superiorly, sir, we can flex the neck.
No, one is treatment positioning. Other thing
Hmm.
is whatever your standard borders are there, what else
Hmm.
you could do? And
So
you
we
have to
can,
give a full
hmm.
dose, radical dose,
Yes, sir, we can use block,
without
sir.
IMRT.
So we can use block to avoid the dose.
Blocks,
To
where would you put the blocks? So what are you going to block? There is an oral cavity tumor. What are you going to block?
no, sir.
So
No.
what else you can do, the toxicity? You said you would prescribe the dose at mid-plane at the ISO center.
Hmm.
So what will happen? So
Hmm.
the ISO center here is just below the chin. That's what will be the separation, expected
Uh,
interface separation there
so,
at mid-plane?
yes, so we'll use a tissue compensator, sir, in
Tissue
this
compensators. Okay.
patient.
Okay. So in what ways tissue compensators would help? In what
So,
way?
tissue compensator is a, huh. So for missing tissue, it will compensate, sir. So we'll be able to apply a standard
What
depth dose
specific
and ISO dose chart.
what specific toxicity, late toxicity we used to get in the pre-IMRT era that will be reduced
For
by
skin,
tissue compensators.
so
There's a name for
skin
that.
toxicity, sir.
What?
Uh,
Skin toxicity over the
mm.
cheek, skin, or where in the near the collarbone region, or where? What skin toxicity? Where would be the hot spot? Again,
The neck,
simple
sir,
thing.
neck. Uh,
Neck is full. Which part of neck?
so the anterior part, sir.
Anterior. So anterior midline fibrosis, subcutaneous fibrosis, because of you would get 108, 110, 115%. So by tissue compensators, you will
Hmm.
look at it because our department has not given up using tissue compensators. Many departments don't make it. You should
Hmm.
know in this case. Okay, carry on.
So to answer Anuj sir questions, sir, he asked about the palliative dose fractionation. So, sir, there is one study from our institute by JP sir. So, in this, they have used 20 grain 5 fraction. There is another regimen which can be used is cord short
No,
regimen.
1 minute. So, which study has told 20 grain 5 fractions? Which paper are you referring to? And one more thing I wanted to ask is when you see in the OPD a
Hmm.
patient, for example, not this patient, like in the same situation, if the patient is having a grossly unresectable disease and they have deemed it as unresectable, upfront unresectable, no role of NACT, intent is going to be palliative.
Hmm.
Then what is the dose fractionation? Sometimes you see when you work up cases in the OPD, you write for palliative RT in escalating doses. So I think all of you would have written depending upon tolerance. So do you specifically see any studies where you can quote here? And what are the other regimens? Not only in our institute, what are the other regimens followed for palliative treatment in head and neck cancer? So what you mentioned as 20 in 5 was
No,
not
sir. Sorry.
correct.
So it is a 40 grain 16 fraction in JP sir's paper. It was hypofractionated 40 grain 16 fraction, sir.
And then 40 grain, 16 fractions, and what was the endpoint of the study, and which group of patients? So this was palliative treatment for head and neck cancers, right?
Yes, sir. It was for
So
unresectable head neck. Yes.
so patient went on to receive 40 gray in 16 fractions,
Yes, sir.
and for which group of patients was the dose escalated then? So what was done after 40 gray in 16 fractions? Was there any assessment that was done? or the dose was stopped there?
So the endpoint was symptomatic relief. So
No, so
I'm not
see,
sure
so
about
the
the dose escalation, sir.
So that's what. So the patient was started on 40 grain 16 fractions, and the patient was assessed after 16 fractions, because if the patient had significant toxicity or if the patient did not find any sign of clinical improvement. So for palliation, what you have to understand is you are trying to palliate the symptoms, not trying to cure the disease. So after 16 fractions, if you feel the patient did not have any relief or the patient is having significant toxicities, then the patient's treatment was stopped at 16 fractions. And those patients who had good response for the planned treatment of 16 fractions went on to receive another 10 grain 4 fractions, making it a total of 50 grain 20 fractions. Okay, so that is how the study was done. Okay, and leave about this paper. What about any other regimens that you know of? Can you name some other regimens that are used in palliative treatment of head and neck cancers?
Sir, there is one regimen called cord shot regimen, sir. So in this regimen, we'll give 4 doses, sir, in 2 days. So on in a single day, we'll give 2 doses. So yeah, 6 hours apart, and the total dose will be, sir, 14 gray. And if the response is good, we'll repeat it, sir.
When is the response done? So what is quad here? What is the quad shot?
So 4 weeks. After 4 weeks, we'll assess the
No,
response.
so no, I was asking specifically what is quad here in quad
Four.
shot.
So four
So
fractions
so
in
two
2 days.
two fractions in a day, two fractions in the next day. So total of four
Yes.
fractions, that is the quad. Then
Yes.
after that, you call the patient after response assessment for about 4 weeks or so. Okay,
Yes.
then you assess the patient, then you give another quad shot. So like that, 2 to 3 regimens of quad shot are given. So that is one fractionation. Anything else that you know of?
So we can give 20 grain 5 fraction also, sir.
That you
Yeah,
have
20
mentioned.
grain. Okay. So have you heard of the Christie regimen?
No, sir.
Okay, so go and read that also.
Yes, sir.
Okay.
So in
And
addition to fractionation, in head and neck radiotherapy, even palliative radiotherapy can cause mucosal toxicity. See? So what should be your
Yes.
volume? If suppose the patient had this same disease and only level 1 or level 2 nodes were involved, then what would be your volumes? And it is palliative. Okay, so we are making it completely unresectable and it is a palliative treatment. What will be your volume be?
So in palliative settings, sir, we'll treat only the primary tumor with adequate margin, sir.
And suppose someone has gross nodes, palpable nodes, you will leave it.
Um,
So your margin, so your level 1 and 2, you have
hmm.
to,
Yes, sir. Yeah.
suppose 2 centimeter node is there and you will not leave it. It is just coming at the edge of the field. When you will go, it will be at
So
the edge.
we'll include also, sir. We'll include that also, sir.
So
No.
the principle is you will not treat very with large fields. Okay.
Yes. Yeah.
That is not required, especially when you want to do high dose per fractionation. So Christie philosophy was use small portals and high dose per fraction and short overall treatment time.
Hmm. Okay, sir.
Suppose the same patient, after the treatment that you had done,
Hmm.
after 7 months or 8 months, there was disease progression. There was response. I mean, you could never show that there was a complete response. There was some post radiotherapy changes, thickness, induration, and then after 8 months, there was a symptomatic clinical radiological progression. What will you do? Will you just put patient on morphine or would you attempt something else? And he's still, in his early 40s and relatively well preserved.
So, sir, disease progression radiologically, sir, at the depending on the sites are local regionally only.
Yeah, so it is loco-regional progression. PET CT doesn't show any other disease anywhere else. It is he's having pain, and the pain is increasing, difficulty in eating, and the skin is becoming slightly ulcerated. You can see that the skin is going to just give way. it has progressed clinically, and on imaging also you see there is progression. Lymph nodes have not really increased. I mean, they have appeared, but they haven't fungated or not extensive. So what will you do? And it was previously also inoperable, and now also inoperable.
So, sir, if the disease is only local, if
Prachi,
matlab, if it is only in buccal mucosa, sir, patient setting, if the intent is still curative, we can has a loco-regional like yes, sir. Which one? Sir, if the patient
I think your sound, I have lost it.
yeah, I think your network is not a good, Prachi. I thought it is my side problem.
Yeah, yeah. I also.
Yeah, okay.
I think, you're talking of recurrence. To begin with, the prognosis was not good because the patient was young and relatively fit. So you had done, radical treatment you had given. It has progression. So first of all, at that point of time, I told you the symptoms. Okay. So you have to talk about symptoms also. Symptom control is the first thing. Just because you cannot do surgery, so symptom control. And then the question is whether you will give systemic therapy, which could have some desirable effect, or re-radiation. And if systemic therapy, which systemic therapy? If re-radiation, what volume and what doses? So, and Anuj and Shweta, you all can tell what you all are currently doing in the head neck units in TMH. And I think Samarpita is also there. Please.
Yes, sir. So you are telling in the event of a progression, sir, or in a re-RT setting?
No, so that disease has progressed, and
Okay.
the patient, it's a local-regional progression. Patient is still well preserved and has
Okay.
pain and difficulty in swallowing. Skin is, looks that it might ulcerate. So in this setting,
Okay.
what are the treatment
Okay.
options? In
So,
addition to symptom control. I
okay, sir.
think that
So,
we not be able to answer this is a little difficult question, so you can
yeah,
just
yeah, yeah. Okay, so in that kind of a situation, sir, if we have already given radiation also, then what we also get an opinion regarding any palliative chemotherapy that is possible for the patient, whatever lines has not been previously received. So in this kind of a situation, if OMCT is feasible again, if the patient has got difficulty in swallowing and various other toxicities, whatever regimen the patient can tolerate will be considered at this situation. And other than that, only symptomatic treatment. So at loco-regional progression, in unresectable or very like advanced recurrent metastatic cancers, there are certain chemotherapy regimens that have been followed. Some of the regimens have been extreme for cetuximab, then pembrolizumab is given as immunotherapy, and nivolumab also, low dose nivolumab. So these are some of the regimens that have been practiced for recurrent metastatic
So
or
this patient did
progressive.
not have any financial constraints. It would have been cetuximab and
Yes,
immunotherapy.
yes,
That would have been the first this thing. And if
yes,
obviously the patient can't afford, then OMCT, metronomic
yes,
chemotherapy.
yes, exactly.
So
Yeah.
re-radiation in this setting, would you attempt, or would you attempt re-radiation? I mean,
No, sir. In this setting, we would not attempt re-radiation if the patient has already received the full course of treatment. So
and it is just
ideally,
8 months
yeah,
disease-free interval. That is all.
it is just a very short disease-free interval and progression. So ideally, we will not attempt re-radiation. It will only add to the toxicity. So it will only be some form of chemo which the patient can tolerate, and other than that, supportive care.
Okay. So I think we complete the oral cavity. Now for the remaining head and neck, we will one session would be on larynx. Both will cover early glottic cancer and other larynx, which is T3 larynx. then hypopharynx 1 session, and 1 on nasopharynx. So it will be, I think, 3 more
Oropharynx.
sessions. Do you think it will cover entire head neck?
Yes,
Yeah,
sir.
oropharynx.
Oropharynx
Yeah,
we
so
missed, sir. So yeah. Okay.
oropharynx 1, oropharynx,
Okay.
larynx,
Okay.
hypopharynx, and nasopharynx.
Yes,
Oral
sir.
cavity,
Yeah.
we had 3 because it's the most common cancer that we see, all different scenarios.
Yes, sir.
Okay,
Yeah.
thank
Okay.
you.
Okay.
Bye.
Thank you, sir. Yeah. Thank you.